Hello everybody, my name is Matthew Simone with Empire Surgical, and today I'm going to be doing a follow-up video to last week's video on shoulder anatomy with shoulder pathology. Now, first things first, we're going to do some background information on shoulder pathology. Every year, over 8 million people in the United States go to see a doctor for some type of shoulder pain. That's a lot of people. Now, shoulder pain can be classified into over-the-head shoulder activities, acute injuries, chronic injuries. Now those injuries are seen in athletes that perform in athletic environments, workers that have work-related incidents, people doing everyday activities such as walking, or you can be born with it, and that is called congenital. Now, when you address shoulder pathology, it is important to address impingement bursitis, rotator cuff and labrum tears, and adhesive capsulitis, which is known to many as frozen shoulder. Now, impingement bursitis is the first one. Impingement bursitis is located in the subacromial space. Now, the subacromial space is located so inferior to the acromion bone. However, it's going to be superior to the to the rotator cuff. So if here's your bone socket joint, and this is your rotator cuff covering the humeral head, it's going to be here, but underneath the acromion, so you're going to have in this little area. Okay? So that's the space we're talking about. Now the impingement part comes off a bone spur from the acromion, which is also called a hooked acromion. So as you have this space right here, with the bone socket here, you're going to have a little impingement right there. So instead of being flat, we're going to have a little curl. And this little curl has the tendency, the ability to scratch bursa and the rotator cuff. Okay? Now that's where the impingement bursitis comes. So, the symptoms of this: you're going to have aching, difficulty taking your hand and putting it in your back pocket, because as you can see, watch my shoulder, as I raise, you see my shoulder raises, so you're going to have your hooked acromion, and as your shoulder raises, it's going to go into it and then scratch it. Okay? You're going to have a difficulty time sleeping. And you're also going to have a catching sensation. Now, a catching sensation is when you go to move your shoulder and it just stops and you're like, what was that? It kind of hurt. Ow. So, now, two ways to fix this is a bursectomy to remove all inflamed bursa, which is done with either a vapor or a shaver, or the other way is to do a shoulder decompression, which is known as the acromioplasty, which is when they take the burr instrument and they shave away the bone spur, so that way the acromion is back to its normal spot and there is no impingement. Next, we have the rotator cuff tear. Now, rotator cuff is very important to the shoulder joint. The rotator cuff is control of all overhead motions. Now, last week we said there were 4 tendons in the rotator cuff. And the 4 tendons are the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. The 2 most commonly torn tendons in the rotator cuff are the supraspinatus and the infraspinatus. Supraspinatus being the number 1 most commonly torn tendon of the rotator cuff. So, how do rotator cuff tears come about? Rotator cuff tears come about from degeneration, from overhead motions, or degeneration from aging. They can also come from impingement, that's in the subacromial space, like I said before, with the little scratching, or from extensive force. So big time force, if you fall and your shoulder and your arms are extended and you hit the ground, putting extensive force on the rotator cuff. So now some symptoms that you're going to see with it. You're going to see pain and weakness. So you're going to be in a lot of pain. It's important. It's an important part of the body. You're going to have the inability to abduct. So you're going to have a problem abducting your arm, lifting it up. Then there's also going to be a catching sensation. Just like the impingement, you're going to be like, ow, what was that? It's your catching sensation. Now, when you talk about rotator cuff tears, there are 5 rotator cuff tears. And the 5 rotator cuff tears are crescent, which is like a little moon, U-shaped tear, which is like a U, it comes down. You have vertical tear, which is kind of like this. You have a inner substance tear, which is on the inside of the rotator cuff. So it doesn't touch the bottom, it doesn't touch the top, it just sits in the middle of that. And then you have the L and reverse L-shaped tear. So take 2 L's, draw them, so you're going to have your little tear, similar to that. Okay? Next, we got labral tears. Now, I myself have torn my labrum and have had it repaired. Okay, so I'm speaking a little firsthand here. Now, the most important symptom, the only symptom really, with a labral tear is a very strong catching sensation. So if you tear your labrum, there's going to be times when you're just moving, you be walking, and you just feel a little catching sensation. You're just like, damn, it hurt. And then when you start doing it, it starts catching, it hurts a lot. It's a lot of pain. Now, the causes of labrum injuries, 2 causes. Okay, you have acute and chronic injuries. So I'm going to give you an example of both of them. Let's give you an acute injury. Let's look at the New York Yankees, for example. Let's use Brett Gardner. Brett Gardner is a left fielder who has an incredible speed. So he's a base stealer. Let's say Brett Gardner takes off from first and steals second base. He goes in head first. When touching the base, his shoulder dislocates. It pops out of the shoulder joint. That is called an acute injury. It fully came out of the socket and done. Labrum fully torn, dislocation. That's an acute injury. Now, a chronic injury is something like I had. I slid in to second base, stealing, and subluxed my shoulder. Now, a subluxation is when the shoulder joint doesn't completely dislocate from the joint. It slides and goes back in. Now, when that happens, you're sliding across the labrum and you're causing a slight tear. And what I did was, when I went into second base, my shoulder subluxed, went back in, and I continued to play through it. I played through it for 2 years. So over that 2-year period, all my constant throwing, my constant slides, my constant swings is just constantly just shaving away, fraying away, degenerating my labrum. So that constant just playing through, scratch, 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 chronic injury. Now, there are 2 types of labral tears. Okay. First one is the superior labrum anterior posterior, which is known as a slap tear, and it is located from 10 o'clock to 2 o'clock. If you look at the glenoid is a perfect circle, and if you look at it like a clock, you'll see 10 and 2 on top, so it's going to be in this little region, slap tear. Then you have the Bankard tear. Okay, the Bankard tear, whether it goes from 2 to 5, or 7 to 10. Depending on what shoulder it is, determines the time of the Bankard. If it's a right shoulder, it goes from 2 to 5. If it's a left shoulder, it goes from 7 to 10. Very easy. Finally, we have adhesive capsulitis. Adhesive capsulitis is also known as frozen shoulder. Okay, this is very, very common with people that have injuries and limit themselves or restrict themselves to shoulder movements after their injury. Now, what happens is that the tissue fuses together, and it fuses together on the joint capsule. Therefore, it's all tied in tight. And from that, you get chronic inflammation because you have all that inflammation, all that tightness. You can't move. It hurts. It hurts when a little tweak. That's why it's called a frozen shoulder, because you literally have your shoulder here and you can't move it. Okay? Now, way to get rid of adhesive capsulitis is to go in surgically and break up all that fused together tissue. So that way you get your mobility back and you're not stuck together. This has been Shoulder Pathology with Matthew Simone. Thank you very much for your time, guys. It's 11 minutes and 10 seconds. I outdid Chris on the time here, so I apologize for that. If you guys can get around to this and leave me feedback, I appreciate it tremendously. As you can see, I tried working around the room because I feel like in all my previous speeches, I've just solely been focused right on the camera, and even I got some feedback saying, hey, I can't tell what kind of angle you're working on, so I wanted to work on looking left, straight, right, looking back and forth. If you guys have any tips to help me to where I can circulate around the room while talking and getting my point across, it'll be deeply appreciated, guys. Thank you very much for your time, guys. Have a wonderful weekend, and I'm looking forward to getting after it again on Monday. Have a good weekend, guys.